discuss this very sensitive topic that is of relevance not only in the country but in the region and the continent. So the most pressing needs for pharmacy education in Kenya can be addressed against the background that in Kenya we have already 7 schools that are training pharmacists, and all of them are offering a Bachelor of Pharmacy program. It takes 5 years. The schools are at various stages of development. There are those who have been there for a long time, fully accredited. There are those who have graduated, some students. There are those who have not graduated, then students are still in the developmental stages. And I know at least 2 schools who want to start a Bachelor of Pharmacy program. Now, there are common needs that can be identified. The first one is academic capacity, which is low. And here we are thinking about the number of qualified teachers in the pool. Currently, all the qualified teachers are engaged in teaching in these universities, so the pool is dry. And those that are teaching are low in number, and that gives a poor staff-student ratio. And therefore, what the universities are doing to make do is either to poach from other universities or to engage staff from other universities on a part-time basis. But you see, that does not solve the problem. That is something that we need to address. Secondly, to increase the quality of our teachers, we need to undertake advanced specialization and be teacher practitioners and remain true to their specialization, so that if I am a specialist in pharmaceutical chemistry, I don't end up teaching clinical pharmacy because there is a need. So fidelity to your specialization is important, I think. Then there is the issue of mentorship and succession planning, so that when our older colleagues exit through retirement or other means, they are replaced by suitably qualified academics. Currently in Kenya, we are facing a situation where our first crop of teachers are retiring and we don't have suitable replacements, and that's creating a problem. The other problem we just recognized over time is that our academic staff are in classroom teaching and need to be retrained so that they focus on the application skills that will be useful to the students when they graduate. So that is it for academic capacity. The second theme that I would like to talk about are the teaching facilities, which are inadequate. It is generally agreed that to deliver a good pharmacy program, you need a wide range of equipment and facilities, and these facilities are expensive. And if you want to approach our top management, they will tell you they have no resources because our universities are cash-strapped. Now, for example, all the equipment, they are very costly to buy and to maintain. If you want to buy a liquid chromatograph, it's going to cost you about $60,000. And the management is not ready to invest that kind of equipment, because when they compare your cost and others, they really cannot see immediate value of spending that money. So the same reason there is lack of skills labs and other simulations that can be used for teaching. I think my colleagues have illustrated the need of this new innovative teaching method for skills acquisition. Then we have the teaching hospitals. Only a few of them are designed to be teaching hospitals. Only a few of them have staff who are qualified and have time to participate in teaching our students, because the hospitals have employed staff for their own purposes. So when we send students there, it is like we are burdening them. And therefore, universities need to have arrangements with these teaching hospitals, appoint these staff as actual faculty, train them so that they are able to deliver the curriculum content as required. Number 3 is about experiential learning, which is limited. In my university, we have a 5-year program, and we are sending out students for a 12-week attachment, during which time they have to go through the 3 main areas, that's industry, community pharmacy, and hospital. We think that that's not enough to give them the skills that they need, and that it's coming late in the course. It would be more beneficial if these attachments started early in the course, maybe after first year, and that we release time that we are using for classification, so that we attach these students and they get and develop the hands-on skills as they advance in the course. For example, if we have a 6-week academic year, we could reduce that to 3 weeks, so that the 3 weeks are meant for attachments. And these students can be attached in diverse areas, in the community, in the health centers where they will be working with nurses and clinical officers and even doctors. And that will offer an opportunity for interprofessional education, which is required in this era of UHC, because multidisciplinary teams are likely to benefit from the insurance schemes of the UHC, because they will be dealing with organizations and not individuals. And these, if students are trained together, medical student, a pharmacy student, and a nursing student, they will have that collaboration after graduation. I have talked to some of our graduates, and what they tell me is they go out there, they have so much knowledge, but they are not appreciated. And one of them has actually told me that such attachments will come in handy in improving that professional relationship. The other thing is about attachment sites. They need to be qualified in terms of facilities and also the staff that are involved with the preceptors, so that they are able to deliver on the objectives of the curriculum. So we must train the preceptors and certify, so that when we send students to the site, you are a certified preceptor who can train. And experiential learning will expose our students to service running. Okay, so they are running as they are offering services, and this will enhance their organizational and interpersonal skills, which are necessary for practice and education. And then to make all this happen, each university should establish an office of experiential education district that is recognized and supported by top management to actually facilitate and organize the logistics of these attachments, so that it is not hurdle, and that we need to develop the necessary toolkits for assessment of these students to see whether the outcomes are achieved, whether the skills are acquired, and that this goes into their academic records and becomes a condition for qualification with a clear acceptance criteria. And number 4, I want to talk about the issue of use of IT-enabled programs, which is desired. I'm thinking about online e-learning modules and other multimedia resources, such as video, specialized software, and others, which, if properly used, will release time that is normally used for classroom teaching, so that this time can be used for experiential learning and skills acquisition. I already gave you an example of reducing the academic year, so that time is used for experiential learning. This has to be done within a framework in which you have agreed with the county governments and the facilities, so that they are aware that your students are coming for attachment, and that they have the facilities and staff ready for that purpose, because we are all working for our country, and therefore everybody has to be involved. Once students graduate, they are serving all of us. And I also know that there are several universities that have e-learning modules that have been uploaded. But this needs to be improved. Currently, they are an extension of lecture notes or text material. That's boring for students, so they will not use them. So we may need to improve on the material, include more interactive material, using 3D models or videos, so that the students find it interesting to run on their own. And then, ladies and gentlemen, the 5th one I want to talk about is the overarching need to carry out transformative curriculum review to support all these things that I've talked about, so that if properly implemented, it will enable us to produce practice-ready graduates. Now, I want to look at various aspects of that review. The first one is we need to remodel the curriculum to address the health needs and the pharmacy practice dynamics that prevail in the market. Secondly, there is a problem that we have recognized over time, and that is vertical and horizontal integration of courses so that the students have an integrated acquisition of knowledge and skills, so that if pharmacology is teaching antibiotics, chemistry should be teaching that, and of course, clinical pharmacists should be teaching about the applications of that. And that should be going in tandem with the attachments. And the other thing is that such a curriculum should actually adopt innovative delivery or training models that have been shown to work elsewhere, so that we're able to transmit hands-on skill sets at all levels, from first year up to the final year. And we have talked about role-play, skills labs, simulations. This really have to be divided into the curriculum. Just for information, you cannot use a teaching model or give information in your teaching which is not divided. So the curriculum has to be changed to divide what you teach and how you teach it, so that you are able to administer that. And then there is a weakness in our curriculum in that we don't stress the evidence-based practice. Evidence-based practices which should be strengthened, because this is becoming necessary as the students who are there. There's also the issue of scientific literacy. We know that there's a lot of data out there, but we have not prepared our students to collect that data in an organized manner, publish it, present it in conferences like this one. I think that's something that we need to stress. And then lastly, tie all these training courses and attachments up. It is necessary to introduce capstone courses and experiences. Ties it all up, so that the students start acquiring a character, the pharmacy character, the professional pharmacy character has become out, so that you can identify the pharmacist in the student. That's important because it gives them a touch of real life practices that they will encounter once they graduate. That, briefly put, ladies and gentlemen, represents summary of the needs that we have in this country. I want to add two aspects which I think Professor Freya has alluded to. The first one is that for us to achieve this, there is a need to have a country-specific competence framework, so that it defines the competences for us. And then we can reverse engineer those competences into the curriculum. Now, there is previous work, so we don't have to start from scratch. I know the FIP has the global competence framework, which we will need to customize and make it a policy document. We start from there, then we know what to teach and what kind of graduates to expect. Secondly, that it is necessary for pharmacy schools to form a caucus or an association in Kenya, so that they are able to talk to one another, identify the needs, the challenges, and they formulate strategies on how to address that. They speak with one voice and are therefore able to lobby for services from top management. If you want to deliver a pharmacy program, you are going to invest this amount of money. So they know. And then you can be able to speak with one voice, even towards the government and the other agencies. Thank you very much, Chair. Ladies and gentlemen, that is what I have to say.
Thank you very much, Dr. Abuga. That was very detailed and succinct and comprehensive to really highlight the needs. And I'm excited that, we are looking at time, the future graduates, aligning them to be able to deliver a UHC, linking to the KePhSA model, and also looking at the competence framework. But using all that and linking and advocating so that everybody, even the policymakers, know the kind of the graduates that are coming out of a pharmacy school and what they can do and what they cannot do at the different levels of care, so that we are able to also create opportunities and influence change and tie that education to policy change. The teamwork cannot be underestimated, and you really have touched on very key things that even as we look at listening into the other speakers, you as being at the beginning of the continuum of education, for you to turn out the future practitioners, we need to pay attention to what comes out of the source. So thank you very much. Another round of applause as I move on to Winnie. And for Winnie, we want to tap into her expertise in practice, also in lecturing, and also being a Commonwealth Pharmacists Association technical advisor. And I would want to switch gears and ask you, how can we link, or how can we better link pharmacy practice to pharmacy education and close the gaps in between, building on what Dr. Abuga said, and also tapping into your expertise in this domain.
Good morning, ladies and gentlemen. I will start because I'm short. First of all, I would like to introduce my colleagues that I traveled with, Dr. Chaibva, who is the head of Pharmacy Department, Makerere University, and stand and just Dr. a lecturer at the Pharmaceutical. He's very good at it. So sometimes when you look at our students when they come from the various schools of pharmacy into practice, you see that they really struggle to use the theory that they got from classrooms to practice. And that brings us back to the question that is pharmacy education knowledge-based and not like, how do I say, using the order level of thinking, trying to evaluate and synthesize all this information we get from theory. And one of the things that I've come to realize is that when we are teaching our students, we need to use active ways of teaching our students. We need to involve the students. Sometimes students switch off, they get bored when you take over the classroom teaching. So we need to make the teaching practices more active. When we are teaching our students, we need to put less emphasis on pumping knowledge into the students and listening, making the students listen to us more and put more emphasis on putting more emphasis on development of skills and critical thinking. Then we also have to use the order level of thinking using the Bloom's taxonomy. There is the lower level of thinking and the higher order of thinking. And for the higher order of thinking, the students are given skills in analyzing, synthesizing, and evaluating what they just learned in classrooms. Then one of the other ways that has been shown to be useful in transforming theory from classroom to practice is the use of case studies. The case studies are a series of stories that students listen to, but in clinical pharmacy would get a real life scenario from the hospital. And because we have huge numbers of students, not many of them have the ability to form part of many of the ward rounds. So what we do is we get real life case scenarios that the students try to understand and make sense out of all these case scenarios by themselves. Then the other form is reflective practices. When the students come from the different practice areas like the previous speaker mentioned, they need to reflect upon what just happened. when they are reflecting upon these activities, they usually use different theories they have learned from classrooms, experiences that they have gone through, and then they come up with a way forward just by themselves, and there is less interruption from the lecturer. Like, you need the students to come up with their own solutions to the various challenges that they have faced. So in summary, I tried to put all that together, and this is how we do.
But if we don't attend our ward rounds right now, when we get out there, we won't feel the need of doing that because we're not being trained to do that. So it's important for us to actually attend the ward rounds together with the doctors and the nurses, and we're able to also put our inputs during these ward rounds so that the doctors, the nurses, the physiotherapists can see our need. They can see that they actually need us to make good decisions for the patient. So it's important for us to have frequent ward rounds. For us to have once a week, so you can imagine you go to the surgical ward on Monday and you find a patient is there, you take the history and try and see out the medications that they have. After that, you go have a discussion, but you won't really directly influence the outcome of that patient. By the time you come back next Monday, that patient will be discharged. So you really don't have an input at all. So it would be better if we increase the amount of times that we spend in the hospital with our patients, so that we can also have a personalized relationship with these patients. So that when they go home, they can remember, oh, a pharmacist actually helped me. So the next time they walk into a community pharmacy, they'll be like, are you a pharmacist? So they'll be able to also see the difference between the pharmacist and the pharmaceutical technologist, because we're going to show them that we're actually being trained and we are better suited to sort out their problems. Also, the ward rounds would really help us encounter more patient cases instead of just seeing them in the textbook for conditions that you've never even seen. So it would be better to be frequently attending the hospitals so that you can see these patient cases and just improve on your own professional development. So another thing is, I think we should also have more units targeting things that are not really pharmacology and pharmaceutical chemistry, because we really do a lot of this when we're in school. We do the chemistry of all the drugs, we do the pharmacology. It's not that it's a bad thing, it's actually a really good thing because that's really what we are working on. But it would be better if they also put in management units, entrepreneurship units, leadership units, so that when you get out there, you really don't wait for a job, wait to be posted, you might die poor, and also your patients will not get the help. So it's better that when you get out there after 5th year, after you've done your internship, you're able to critically think and see a problem, target that problem, and you can start your own practice to just make a pharmacy better in Kenya. So they should improve on just adding more times when we do the management skills. Also, we have a unit on where we do the Capital for 4 amendments. So, these things, we should really just go critically and look into what is happening, so that when decisions are being made, as students, we're also there and we have an input, because in the future, we're the ones who are going to suffer from the decisions that we need to take part in. So it's important for us to be involved. It's important for us to be active, and the only way we'll be active is if you invite us over and encourage us and mentor us, and also hold our hands as we move together. So another thing is, if I was the dean, I would also encourage student participation in events. Like, this would be a really good event for a few students to come and also meet professionals, meet mentors who would guide them and show them the way, and also just show them how you can be able to make opportunities out of problems in the field. So also students should attend medical camps where they can get more skill sets. They should also attend such conferences. I'd like to also recommend PSK. They paid for a few students to attend the Kenya Health Student Summit that was held in February. So it should also be a requirement for at least a student, before you finish 5th year, you should at least attend one conference. Because the students who actually go from 1st year to 5th year, and all they've been doing is just reading to just get their GPA up there. But when you finish school and you get out in the field, your GPA may not really help you, but the connections that you build are the ones that are going to take you far. So it's important for the school to also allow students to do these things, provide funds. You just give scholarships to students so that they can go to other countries and talk to other students in those fields, and also to just be able to understand what are the students in these different countries doing differently that is improving their health outcomes. So with that, I think I'm grateful. Thank you.
Thank you very much, Prudence. Very good points. Very good points. And we're being challenged, our fellow lecturers, really to create time for ward rounds, more patient-centered approaches. And as a clinical pharmacist, I can resonate with that very strongly. Case studies are not enough, and we have to support UHC, quality healthcare, quality pharmaceutical care, of course without the financial hardship. Really we need to create time for this. But beyond the ward rounds, what about the primary healthcare sites? How do you interact with community health services? How do you interact with the other programs? Talking of more units, that was music to my ears. As an employee, we get very brilliant staff, but some key skills are missing. Leadership, management, motivation, attitudes. What the soft skills that need to get us where we need to go. Okay, moving quickly, I'll move to Joyce Chaibva. Chaibva. Okay, the V is silent. Great, thank you. Africa Pharmaceutical Forum leaders are from an African perspective. What are the key education and workforce development needs in Africa? How can we match the healthcare needs of the society to Africa education system and workforce competences?
Thank you for the introduction. When I came here and was thinking about the key education workforce development needs in Africa and how we can match the healthcare needs of the society to pharmacy education systems and workforce competencies, I was thinking of the classroom where I've got a number of lecturers from the universities, and then the practitioners out there. How well prepared are they, and how do they handle the practice in their various areas of pharmacy practice? But before I talk about that, just as Africa, through FIP, we've got the forums. Those are the FIP forums which try to address the different areas or put together or bring together various countries in terms of practice. In the yellow section there, on the map of Africa, we've got the Africa region. So the roles of the FIP's forums, their reason for existence is to support FIP policies. And as the presenters were there before me, Ralph was talking about FIP and so on, and so was Clay. So the role of FIP as forums is to support the policies, and there are a number of policy documents which have originated from FIP. And one of the issues there, which has also been mentioned, is to strengthen pharmacy practice, particularly in developing countries. And if you look at the number of pharmacists per population, you find that ours in Africa is very low. So a lot of these people in Africa, if you go into the villages and ask them, what is a pharmacist? What does a pharmacist do? You might get very interesting answers. Back home, someone did a survey on a radio and was asking, what is a pharmacist? It was actually Pharmacy Week. And then the person said, it's someone who helps the farmers to acquire fertilizers for their farms. So, it's pharmacists as far as the people are concerned. So, we also need to go out there so that people know what we do. And sometimes we're just talking about the people out there in these villages. Maybe even our politicians don't even know what the pharmacist is supposed to do. So anyway, we also want to facilitate collaboration between pharmacy associations in the region. I know the Pharmaceutical Society of Zambia is invited other associations to come to a meeting, which they are holding next, I think around the 14th of June. They've invited leaders from the SADC region to attend their conference, so that we also learn what other people are doing. And also to collaborate with the WHO regional office to advance pharmacy practice and pharmacy workforce development. So the FIP workforce development goals, there are 13 areas, I think, which have already been highlighted, but I just decided to put them into clusters. The first one on top there, I hope you can read it from there. Anyway, if you don't, I'll read it out. It's workforce intelligence. We have to know what is required. What are you supposed to be doing? Are you supposed to be a pharmacist or a pharmacist? So there's that intelligence which is required, so that we know what is our role, and to improve our job or provide our services. And with that, you need a pharmacy education capacity. I think one of my colleagues has talked about the capacity education in pharmacy, so that we develop the competencies for the services to be provided, which is on number 3 on my cycle there. Then practice and pharmacy services. What are the services which you must provide in the various countries? And in different countries, we've got different needs, and we've developed pharmacy, maybe depending on how our predecessors understood what was supposed to be the role of pharmacy in there. In Zimbabwe, for example, we do have a lot of community pharmacists, and we've got very few hospital pharmacists. But we know there's a gap. But maybe the economy might actually make the politicians not even look or address that aspect. So the practice of pharmacy is sometimes compromised because of the scenarios in our countries. And as such, we need to be involved in leadership and policy making, policy formulation. With our recent elections in Zimbabwe, when I say recent, it must be about 2 years ago. We had, from the elections, we had 3 pharmacists who participated and are now members of parliament. And there's a portfolio responsible for health services. It's chaired by a medical practitioner whose husband is a pharmacist. So last year, when we had the issues with the government in terms of pricing and so on, medicines and so on, and availability, we actually went out as an association, the Pharmaceutical Society of Zimbabwe, and all the affiliates, like the Retail Pharmacists Association, which I chair, Pharmaceutical Manufacturers Association, and the research component and education. We actually said we want to see Parliament, so that we tell them what we want as pharmacists, so that the profession is developed or is supported well. So it actually did help us to actually have people from inside, and we're coming from outside, and we managed to make a lot of headway. Because at that point, even the president himself, when he was talking about the health sector, he was talking about pharmacists being the worst professionals around who are exploiting people and so on. Then when we went there to speak to the parliamentarians, we actually had a nice time. It was a walk in the park, because we had other people already sitting there, and we were talking from outside, and we did make our case much, much better. And also we need to collaborate with other healthcare professionals. Recently we had the nurses were launching their document about nurses as the backbone of healthcare services. But when I went to Amman for the regional conference, the theme of that conference was the role of pharmacists as primary healthcare providers. And us as pharmacists, in community pharmacy for example, we're actually the face of pharmacy. And whoever wants services, they can actually walk into your pharmacy and then they can provide it with services. But we need to actually have been educated, given the right skills. I did a postgraduate training in clinical pharmacy, even though I'm not working in hospital, but I make use of that experience to be able to talk, to help the patients when they walk in terms of primary health care. So strengthening pharmacy practice through FIP, we are moving from the product-centered pharmacy practice to patient-centered and patient outcomes. Remember that the pace varies from place to place. That is from that product-centered to practice-based or patient-centered practice. It varies from country, from region to region, depending also on economic background. But despite these differences, a competent workforce is required. And I'm sure my previous speakers, they alluded to that. Because we have to be able to do that correctly. We have to get the right skills in terms of pharmacy practice. And we also need to get the correct soft skills to be able to do that. So, I think there's a statement, I didn't quite quote it correctly, but I quoted it the way I wanted to. Whenever medicines are being discussed, pharmacists must be at that table. Because policies, they come up talking about how pharmacy should be done. It's being said by the nurses, it's being said by the doctors, but the pharmacists are not there. No. Pharmacists should be there at that table whenever medicines are being discussed. Be it vaccines, be it any other medication, pharmacists should be there as part of the policy making. So strategies for workforce development. So the steps taken should come up with a viable strategy in 3 broad categories, which are namely workforce intelligence, there's needs assessment to analyze the gap, what should be trained, what are the skills or the skill sets required for someone to practice in the various areas of pharmacy. And that involves curriculum development, which is targeted towards the competencies required, and with the correct assessment methods and evaluation and review to see that we are training for the future. Last year, about 2 weeks ago, I attended a curriculum workshop from the University of Zimbabwe Medical School, and the students who were there, some of them were actually complaining that the curriculum which is being used is archaic. It's not training them for the future. Because all those students who are starting their first year this year will be in practice at least in 7 years, if I put internship and other things in between, to be properly, to be fully fledged pharmacists. So in 7 years' time, a lot of things will have changed. So we should never lose sight of the future when we train. Then the next item is about education for workforce development to close that gap. We talked about intelligence to know what is required. And then the education, there's the foundation training, which is the schools of pharmacy. I don't know how many pharmacists are here in Kenya, but in Zimbabwe we've got very few pharmacists, but the population is much bigger. So, and the FIP has done a survey, and I think someone has already alluded to it, that there's the ratio of pharmacists to the population is very low in Africa in general. So there's a core curriculum and capacity of the schools of pharmacy. Sorry, remove that S, it was a typo, is to meet demand. When we went to Amman, I thought it was a very small country in Jordan. And they told us that there are 22,000 pharmacists in that country. There's something for them to do. Sometimes we said there are too many schools here in Africa. It's because we are looking at the economy and we are worried that there might not be enough jobs. But the jobs are there. Maybe the economy is pulling us back. So we have to be innovative so that we're able to keep up to date with the needs and the role of pharmacists as primary healthcare practitioners in manufacturing and all the other various of pharmacy practice. Which brings me to specialization and continuous professional development. So we are looking at the products, the whole supply chain. I think there have been a lot of courses on supply chain. There's a gap there, but I think there's been a lot of training through a number of organizations. Manufacturing, distribution, resulting in availability. I like the pharmacoeconomics one because when you look at Ministry of Public Health institutions, the second largest budget is medicines. So if you are there as a pharmacist in public health, for example, you still look at a big budget. So you have to be to have the financial intelligence to be able to run these institutions. Research and development requires a lot of money. You need the financial intelligence. I wanted to talk about community pharmacists. That's the business. Then SEPA is an abbreviation which you use to talk about safety, efficacy, quality, availability, access, and affordability of medicines. So it all comes in to cover the quality of medicines. Then there's regulatory pharmacy. This is a specialization where there's a gap to be addressed. There's a GMP training, dossier evaluation, pharmacovigilance, clinical trials evaluation. I know there are regulatory, Zimbabwe is trying to be, as one of its objectives, our Medicines Control Authority, which is the regulatory authority, one of the objectives is to become a regional center of regulatory education. So it's a developing in that aspect. Then we've got patient and pharmaceutical care. Those are specialized areas, be it in community pharmacy, vaccination and NCDs, adherence, medication reviews in community pharmacy, for example, or even clinical pharmacy and in hospital pharmacy practice. So we need this specialization. Then the third aspect is leadership and advocacy. We should be policy makers to affect our profession. And public office for pharmacists' roles. Pharmacy workforce development. Then we've got the regulatory framework. So when we look at all that, it's into three. It will cover the various areas which will make sure that pharmacy is operating in tandem with each other, regulatory, educational, and practice frameworks. Those are my source documents, which are FIP documents. You can find them on the FIP website. And final message from me as AP Vice President is an invitation to all the members. One, be part of the international group of pharmacists, that's FIP. I'm inviting you to be individual members. And also an invitation is also being extended to PSK to be a member of APF, of which I'm the Vice President. I'm looking for members to lead. And then FIP conference, we've got in Abu Dhabi, I think there's been the flyer which has been circulated in September. And in 2020, it will be in Seville, Spain. And there's the pharmacy conference in Montreal, Canada in 2020 as well. And in 2021 in Brisbane. So please don't tell me that I didn't tell you or I didn't invite you. See you in Abu Dhabi. Thank you.
Thank you very much, Joyce, for the deep conversation. I hope the presentation will be available. I'm sure it couldn't fit in 10 minutes, but those were very good insights. Again, we are all being reminded about very key things that have come out of the presentation and the places that we should really be playing, the league we should be at, and influencing different things. Collaborations have come out clearly, issues of teamwork, a move towards patient-centered care, patient outcomes, and of course, from there, I'm sure you know the people also from the university and other supporting training, capacity building. You're already seeing the needs, the priorities coming, and we cannot ignore issues of pharmacoeconomics. You know, even as a country, we are thinking about health technology assessment. Some of those skills that have come up are really key for us going forward. So, switching gears and moving to the next panelist, Noel from West Africa Postgraduate College of Pharmacists in Nigeria. I want to pose a question to you. How can we create an enabling policy environment to advance pharmacy education and practice? What are the barriers? and what are also the solutions to think about.
Thank you very much. I think I'll prefer to stand because I'm short. While I dropped at the airport here in Kenya, I mentioned 2 words. And the woman asked, "Are you a Nigerian?" And I said, "Yes." In between, she told me that my accent betrayed me. And I said, "Okay, I hope you understood what I said." Today, I'm going to make a presentation that will last up to 10 minutes. I pray that my accent will not betray me, that you will understand what I'm going to talk about. Permit me to very little to tell you about the West African Postgraduate College of Pharmacists, WAPCP. WAPCP was established in 1976 in Liberia, and the first president is a female. After that, we never had another female again until this day, 43 years. We had the second president, Janet McKee, she's a Gambian. From 1976 until 1991, the WAPCP was given a mandate for education in West Africa. 1997, we produced our first graduates, first fellows of the college through examination. And as at now, we have over 2,000 pharmacists that are fellows of the West African Postgraduate College of Pharmacists. At the college, we have 5 faculties: Faculty of Clinical Pharmacy, Faculty of Community Pharmacy, Faculty of Social and Administrative Pharmacy, Faculty of Public Health Pharmacy, and Faculty of Drug Production and Quality Assurance. Of the 5, we run it for 5 years. The first year, they go to primary. The second year, they're in part 1, and they do part 1 for 2 years, and part 2 for 2 years. In part 1, they have specialties in their second year. Then when they get to part 2, they now have sub-specialties. Of course, you and I will know that our curriculum at the undergraduate level puts us more broad-spectrum pharmacists. And more often, we also end up to be surfactant, surface active agents. However, if we had the opportunity of specialization, we would have been a different expert in our field. So the WAPCP is aware. We decided to break it into subsections and subspecialties. So that when you're a consultant in clinical pharmacy, you'll be a consultant maybe in cardiovascular disease, in hematology, in oncology, etc., etc. Same applies to the other faculties. Well, 5 countries are involved: Nigeria, Ghana, Liberia, Sierra Leone, and the Gambia. To be interested to also know, in Nigeria, we have about 21 accredited pharmacy schools, pharmacy universities, and we have a population of about 22 to 25,000 pharmacists. You may think it is a high population. The Nigerian population is about 200 million. And in fact, 200 million is even an estimate, because we have, it's an estimate. I can also tell you, we have some people in Nigeria. We have a musician that each time he visits on any tour, 9 months later the population increases. It's not doing badly, meaning the population keeps growing as the tours are increasing. And in Ghana, we have about 3-4 pharmacy schools with a population of about 5,000 pharmacists. In Liberia, we have only 1 pharmacy school with a total of 168 pharmacists. In Sierra Leone, we have 1 pharmacy school with about 400 pharmacists. In the Gambia, we have no pharmacy school. We have only 18 pharmacists in the whole country, and all of them trained outside the country. That's the situation in West Africa. Next slide. Well, again, what you should know is in Nigeria, all pharmacy schools have been mandated to switch into the PharmD curriculum. The West Africans of which into the English-speaking countries have been mandated to switch over to the PharmD curriculum. I think let's jump so that we can save our time. These are background information on the PharmD specialization so that we can see where do we go to. We're moving again, like what one of my colleagues had said, from the product to the patient-oriented pharmacy practice. Next slide. But there's a need for us to urgently look at more directors, more departments, and then again, there's every need for us to update our knowledge. Generally, the knowledge of pharmacists, there are from my own perspective, is a little scarce. We should be able to have some policies that are local in content, peculiar to Africa, and then there's actually a wide gap between our training and our practice, from what we have seen from previous speakers, so that we want to examples as we go on. Next slide. Okay, this is the raw simple status of what we have discussed. Next slide. Now to the challenges. Well, naturally speaking, without a sustenance plan, relapse is inevitable. We're having a lot of relapse problems in West Africa today. The training of pharmacists is actually very difficult, and we expend more energy in training. I'm happy a lot of my colleagues here have said it. If you look at the curriculum at the undergraduate level, so robust. When you finish the university, you come out of the system, you realize that you do very little of what you have learned in school, which invariably means the maintenance dues is higher than the loading dues. Next slide. What are the expectations? The challenges we're having in pharmacy school, I'm happy a lot of people have mentioned that, our curriculum design. Candidly, our curriculum is totally outdated. I've been teaching pharmacology in the last 20, 25 years. I've never seen guanetidine, I'm sorry to say that. I don't know whether those things are still in practice. If you look at the way the curriculum is and what practice is all about, there is a wide gap. And we need to develop, we need to change it. We need to have a standard. We need to have a standard based on global perspectives. We also need to look at the training. It is a wrong assumption. They think that everybody that graduates has a bachelor's degree, a master's degree, and a PhD is going to be a good teacher. And each time they have a PhD, it is believed they should go to the academia, go to the university. Most of us teaching in the university, we are not trained. We just found ourselves because we got a PhD and people say, go and teach. And we are teaching. Whether we deliver or not, we are paid. And we graduate them. Once they're out of the system, it's not our business any longer. I think we should also develop a curriculum for training the trainers. It's very important. Aside from that too, the delivery is also poor. In fact, in my university, some of the lecturers are so always frowning, hard-looking, unfriendly, because the more you smile, the more they will look down upon you. And the students come out with this timidity and low self-esteem. So when they're in the society, they feel a second generation, second degree, second citizenship. So the elders must talk. That's why I'm happy. The student here said, if you are invited, let's start from now. The students will come in and then let's close up the gap. I think the curriculum is very, very important. We should look into that. And then human resources to capacity building. We lack that in West Africa. A lot of the universities, in my university we have about 52 lecturers. Out of the 52, some of them are trained, some of them are not trained. And incidentally, as you grow in the system, you eventually made head of department, you eventually made a team. I've never attended any training for management or to be HOD, but I've been HOD twice. I've never been trained to be a dean or a director, but I'm a director by age certificate. I think there should be that correlation so that we can preach in what we do. Then, the most important that a lot of people don't want to hear is funding. Our universities are lowly underfunded, very lowly underfunded. In fact, when I applied for my research grant, the first research grant I had was 78,000 naira. Those of you that know what naira is, that is about $200 research grant, which is just enough for me to sit in a staff club and discuss with my colleagues so that I have the mental frame to start research. And with $200 from Rabbi. That's what is given to us at the academia for research. So we are grossly underfunded in research and in training. A lot of things must be done about that. Then, of course, my colleague here, when he narrated about infrastructures, I felt he was talking my mind. We have the same problem in West Africa. Our laboratories, some schools of pharmacy still use cooking stoves and gas in place of Bunsen burners. Okay, somebody will start firewood too. Oh, is actually a crude decimal. We are shortchanged in terms of infrastructures. Now, the pharmacy schools too, there are a lot of things that are expected. We should create opportunities for faculty and students to interchange, have exchange programs, maybe students from this country should move to another country, students from this university within the country should exchange so that we can have ideas. They do that for both the students and the staff. That is going to enrich, also we learn from what they do, and then we exchange ideas. And our trainings are too abstract, too out of place. We need to introduce more hands-on, increases our practical skills and competencies. And of course, periodically, we should participate in classroom teaching of the students. Most times, the lectures go on, no supervision by mentors. If you have a mentee, and you just believe that you have done it. And there should be also an independent evaluation, especially in residency training. At West African Postgraduate College, we know that the wide gap is as a result of non-practicability. In fact, in my country, all pharmacy schools are not located in the hospital. Meaning, pharmacists are the only professionals that are trained outside where they're going to practice. Yeah, if you are a doctor, you trained a little outside the campus and then you end up in the hospital. Nurses, same. Medical labs, same. The pharmacy is the only school that you can train outside the system till you graduate. And that seems to give us a wide gap. The collaboration is not there. We don't really know how to communicate, how to link up with these professionals because we're up initial that introduced. Then there's also expectation from government. Funding. They will never have money. If it is education, they will never have money. But again, most times, if you look at the money that is being budgeted again, I don't know where those, actually I'm very confusing. I don't know what is budget and what is reality. You see huge figures being budgeted and no figure being given. At the end of the day, the year is over. Next year, another budget, another budget, another budget. Little wonder. A friend visited, a minister visited a friend, and then took him to his house. The friend asked him, you have a beautiful house because of big house, big TV, big cushions. How did you get this? Pointed at the road. He said, see that road there? 10% is here. Then he came to another country, in Africa. Got his house, big house, swimming pool, imported everything. And that is impressive. How did you get here? Beautiful environment. He pointed to the road outside with potholes and everything. Did you see that road up there? He said, yes, 100% here. It could be budgeted, but you see nothing. Of course, then the political will. The government is not really ready to do some things. The policies are twisting. In my country, in West Africa, the policies are more favorable to medical doctors, physicians. Whatever they want, they're giving. Unfortunately, our population is so low. Even Nigeria, that is supposed to be the highest, we have just 25,000. And unfortunately, we don't participate in politics. This is where decisions are made. We have to encourage ourselves to partake in politics, right from the student union level. In fact, some lecturers will even tell you, if you participate so much in politics, you will have carryovers, you will withdraw. And then the students are discouraged from the beginning. So when they come out, they lack that confidence to participate in politics. We have to really encourage that. In fact, I contested in 2003 in my country, House of Reps. I had 728 votes. Out of these billions I mentioned, I had 728 votes. But it's okay. Let us be part of it. In fact, if we are into politics, we are going to be policy makers. I was invited for a conference of nurses, and I realized the high table was super rich. The dignitaries, who in Nigeria participated. And I was wondering, and I thought and I asked, I like these nurses, very interesting. You mean you could put this crowd? Then somebody whispered to me, the vice president's wife is a nurse. So if the women, please, if you cannot participate in politics, technical support. We should be able to reach out to government. But a lot of other professionals quickly reach out to the government. If there's a change in government, the one they did in Zimbabwe 2 years ago, I am tempted to believe that pharmacists did not pay a visit to the president. I'm tempted, I'm sorry. If there's a change in any policy, we should be able to be proactive, quickly mobilize ourselves, pay a courtesy call, and then make one or two demands. We breach the political gap. We should be able to have technical support, FIP, I hope you are listening to this. Even if we have not solicited, with the areas of problems I've listed, you should be able to see where can you assist. We need more universities to have our impact, to have our touch, so that we can feel FIP. We need more collaboration. Collaborating programs, PSK, collaborating with PSN, collaborating with West Africa. I give thumbs up to Nila to have invited me for the first time in this conference. And I can assure you, I will continuously attend your functions from now onwards. We should consider other centers. We should establish more centers and key places. I mentioned that. Next slide. Again, having discussed barriers from the universities or schools, barriers from government, we also have physical barriers. These physical barriers now is weak. In fact, it will amaze you to know that some people are just allergic to progress. Some pharmacists on their own are the problems of pharmacy practice in West Africa. When you look at number one, they have low knowledge. When you were in the university, very excellent people. I teach pharmacy students, I teach medical students in my university, and I tell them. In the university, a 300 level medical student can offhandedly outshine a 500 level, 600 level 300 level pharmacy student will outshine a 500 level, 600 level medical student in terms of intellectual stamina. But give them 3 years post-graduation. As the pharmacy student is going down the ladder of academia knowledge, the medical student is climbing up because he reads constantly, he updates himself. The place the pharmacy student, the pharmacist now will tell you is the price of paracetamol in that street, which is too bad. We are also a barrier to it. Low knowledge. Some of us just don't want a change. When you want to suggest a change, they will say you are walking or moving faster than your steps. I have been a pharmacist in the last 30 years. We don't do things like that. Take it easy, young man. We have done a lot. And then some of them have information overdose or underdose. Most pharmacists are not innovative. We need to have disruptive innovation. We should think outside the box. The way we are trained, we have this straight-jacketed way of thinking, it has to be so, if not never. We should explore. In fact, don't just think outside the box, through the box. Work without the box. There is a wide gap between training and our clinical behaviors. Next slide. Thank you.
Wow. That was powerful, that was real, and I'm sure it resonated with most of us. So we are barriers ourselves. Yeah? We need to engage, we need to lobby, we need to advocate, we need to meet new leadership, need to be engaged in politics. And politics may be in different aspects, but even as we are thinking about some of the things we were discussing yesterday, I think we've been challenged. We can pick some tips from Noel, and even start engaging the new leaders as we start, influencing and probably getting, our pharmaceutical services directorate among others. But think outside the box, or through the box. I know we are time bad. We've gone a little over, but we cannot close this session without hearing from Professor Ndemo, just 2 minutes, and would like him to share the PPB thoughts on the ongoing curriculum review that's being done by the 7 universities. Thank you.
Thank you. Can you hear me?
Yeah.
Now, actually, I'm standing before you as the chair of the Training and Assessment Committee in the board. We, at the moment, we're actually working on revising the curriculum, but obviously, all the thoughts and ideas we presented before the stakeholders. But generally, the key issues have already been addressed by Dr. Abuga. Number one, you are aware that actually most curriculum that you have in the 7 universities is cut and paste from the University of Nairobi. They're all the same, more or less. And you do this typically is 5 years of pedagogy and then obviously 1 year of actually internship. I happen to be a hybrid. I wasn't introduced, so I was a graduate from Leicester School of Pharmacy in UK, and then also did a Doctor of Pharmacy on a Fulbright scholarship at the University of Minnesota. I've been teaching in the US for the last 16 years. So I believe I was the first Doctor of Pharmacy in this country, the first one to introduce clinical pharmacy in the school. I want to tell the story. I've been fighting for the pharmacists, that's for another day. But the plan is, essentially, we're really interested in the competency framework, in the sense that I'm trying, at least personally, to make sure that the internship is university supervised, just like in the US. In other words, what has been happening in this country is that, in fact, the students just shadow all over the place, and half the time they're reading newspapers. But we plan to incorporate the experiential year, the internship year into part of the experiential year. And again, the capstone courses that Dr. Abuga was alluding to was important. And the other issues we'll have to debate, not this time because I feel under pressure to finish. The thing is, we need to decide, when we talk about practice-ready pharmacists, what knowledge and skills should these pharmacists have? Should this pharmacist be having a knowledge level at the undergraduate level, or should he be talking about graduate? If you follow the trends in the US, in most cases in California, it's a 4+4 years, and slowly, increasingly, all the pre-pharmacy students the tendency is towards actually completing the first degree before they do the professional program. The professional program is not like the model we have here. We need to be rethinking, re-engineer, and just make sure that we have a practice-ready pharmacist. So at the moment, we plan to, the course is going to be slightly longer, that's a suggestion, but we will make sure that they have the competencies. And again, the other thing is that we are cognizant of the fact that we still have industries. There will be an emphasis on other areas like pharmaceutical analysis, which is not a big thing in the US, or industrial pharmacy. That will not be forgotten. There's a lot we can learn from West Africa in the program. I've been dealing with a professor from Ghana, and actually I'm quite impressed. And our previous speaker, who is very impressive. There's a lot we can learn from each other. So all in all, I'm ready for change. I'm not allergic to changes, so thank you very much.
Thank you very much, Professor Ndemo. We have so many questions for our panelists, and you know why. And I don't think they'll be able to respond to all of them. But we need to come up with a strength, to wrap up and summarize the response in 2 minutes, but also urge them to go and work on the responses and share them with the PSK Secretariat so that they can be uploaded, on the website. Is that in order?
Yes.
Okay, thank you. So we thank them for being very insightful, for the thought-provoking discussions. We're just going to go one by one, starting with Dr. Abuga, 2 minutes, to try respond to one of the questions or all of them in 2 minutes, but do a more comprehensive response for KePhSA. Thank you.
Okay, thank you very much. I think I got the questions. There are like 11 questions. I've summarized them. But most of them are really revolving around the issue of curriculum review. I want to state like this. The University of Nairobi, in collaboration with the other universities under the SPHERE program, have undertaken to perform a comprehensive curriculum review that will incorporate all the questions you have asked here, whether we want to incorporate case studies or ethics and behaviors, pharmacy leadership, supply chain management, field experiences, all those that we have raised here will be captured. And we are ready for change and innovation in delivering our curriculum. I got an interesting one here about the role of the regulator. The role of the regulator is very clear. The regulator comes, they will do audits, and they will follow up. If they just do their job, things will go as planned. What happens is that they don't do it, or they don't do it regularly, and that's where you have problems. I saw something about the experiential learning. Is it going to dilute the intellectual capacity that we are expected to impart at the university level? And the answer is no. We will have different sections of our curriculum. There are cases where we improve the intellectual capacity of the students, but for purposes of practice, we are going to create time so that they have the experiential learning. So the two of them run concurrently, and experiential learning will not be done at the expense of the intellectual capacity. Guidelines and policies, these have to be done through consensus building. And the consensus building is a process that takes so many iterations of consultation with stakeholders until you get 100% consensus, and then you're able to roll out the policies. Thank you very much. I think in summary, that's what your questions were about.
I got 3 questions, but they were all centered around the curriculum. And one wanted to know the changes that we made to the Makerere University curriculum. Initially, the College of Health Science curriculum was problem-based learning kind of curriculum. But then along the way, we realized that there were challenges. We had problems with infrastructure and human resource. So the curriculum was revised, and the curriculum is kind of like a hybrid between problem-based learning and lecture-based learning. The other question was about drug shops. Somebody wanted to know if we have drug shops in Uganda. Yes, we do. However, they are not specifically owned by pharmacists. They can be owned by other business people under the regulation of the National Drug Authority. That's what I have.
Thank you. Prudence, no question. Thank you. Jocelyn, 2 minutes, summarize, and then we'll respond also to the others.
Thank you. The few questions which I've addressed, one of them was on interprofessional training. In Zimbabwe, we have the preclinical years where pharmacology and physiology are taught together for the pharmacy students, medical students, and radiography. So there's a collaborative training there. Then someone also asked about membership, being a member, individual member of FIP. That is available on the FIP website, which is fip.org. You can find the application forms, and the fees, they usually depend on the countries, and they've rated them for us. In the lower income countries, like Zimbabwe, it's about 45 euro per annum. That's the annual fee. But of course, those with more money up there, they pay much more. But I think most of us in Africa were around that figure of about 45 euro per annum. Then someone asked about the pharmacy education gap and asked if there's a need to review the curriculum. I think that has already been mentioned by one of the speakers, the need to look at the gaps in the various areas of pharmacy practice, whether it is GMP, regulatory, and so on. Where is the gap in each country, and then it is addressed accordingly. As I said earlier on, they were all at different levels. Others are stronger in certain areas than others. So the need for review of curriculum, and I'm actually happy that the guy from education here was talking about that here in Kenya. And I hope it will spread to other countries in the region as well. Then the competencies will also be addressed, I'm sure, including for community pharmacy practice. Because you have to do diagnosis, and then in some cases you have to prescribe or refer as the need arises. In our country, as a community pharmacy, you have to have what we call a private area, so that you can actually talk confidentially with your client if they've got something they want to talk about, or they've got a condition to be discussed. And then someone asked there about the training, this kind of training like mentorship. I think what has been happening in most places, as one of the speakers alluded to, what we call QBE has been taking place, qualification by experience to be a mentor. So usually because they have so many years of experience, you end up doing certain things without the training based on that. And I think we should be looking into that as they do review, curriculum review, so as to strengthen the various roles which we have to play. And train the trainers, this is where CPD comes in, or continuous education, so that even those who are already practicing, as new things come in, of course, I trained a few years back, I won't say when, a lot of things have changed since I trained, so I've had to do a lot of continuous professional development and learning. Yeah, I think I've addressed all the areas. Thank you.
Very much, thank you. I will move over to Noel.
Thank you. I have a total of about 5 questions here, but I think you have addressed one of John Lee's. But after the 5 questions, one I think came before my presentation. Harmonize it in such a way that if a clinical pharmacist is discussing pharmacokinetics, it should be peculiar to his own field. And then we have a way to hybrid, to bridge them together. That is going to improve the wide gap between learning, between our training and practice. The scope of pharmacy practice in Nigeria is actually evolving. With the recent emergence of PharmD, it has actually shifted base. We are now more into patient-oriented pharmacy practice. The research is still there, the compounding is still there, nothing has changed, but we have moved from the product bias to now patient bias. Then somebody asked about whether there's any legal suit against pharmacists in Nigeria. The answer is yes. The answer is yes. We have a lot of cases now. And until we begin to know that if you do anything professionally wrong, you are going to be charged to court, we may not sit up. In fact, I will even tell my colleagues, during work rounds or clinical meetings, I'll tell them, let us begin to embarrass ourselves. Because if I embarrass you in the presence of a patient and people, you must read in the night before you come and face me the next day. So by that we are consciously, we are aware that this man constantly embarrasses us on the work round. Let us read to avoid embarrassment to help us in bridging our knowledge. Legal implications, plenty of people have been sued in Nigeria, so we are now sitting well now in terms of practice. Challenges of counterfeit drug in Nigeria, the answer is yes. In fact, in my country, I don't know about it, in my country, drugs are sold like cola nuts and confectionaries. They carry them on trees. They move from motor park to motor park, from filling station to filling station. They carry them together with sweets. Whatever your illness is, the man as a solution to it. In fact, to press you for that, I saw one some 2 weeks ago with a bowl, written on the bowl, pharmacy.
Thank you very much, Noel. Let's give a chance to Ralph and Claire. 2 minutes.
So I have one question here. What has been your experience in relationship between pharmacists and the lower cadre of technicians at FIP? It's very much a work in progress at FIP, but technicians are very much being embraced. We won't be able to provide the services, the patient care that we need without having technicians and even cadres below technicians, pharmacy assistants to help us. So technicians have been part of the Fringe program in FIP for a number of years now, and this year for the first time the technician part of the conference is incorporated into the actual rest of the conference, and this is a major shift. I have a colleague called Susan James who is leading that work in FIP. I have a lot more questions here. I'm just trying to think which is the interest. Yeah, I'll choose this one. Somebody said the move towards patient-orientated pharmacy practice is good, but how are we going to ensure that quality product is equally important? Who should take up the product-orientated practice? I think we need both, and we need to train our students to do both. But in Nottingham, we've had to really struggle with this, and we have integrated our course a lot more. So we do modules based around diseases and conditions. And say, for example, we do bacterial and fungal infections as a module. And within that module, we do microbiology, we do pharmaceutical science, we do pharmacology. We have a separate vertical theme for ADME, you'll be pleased to hear. Separate, because it's so important and so much part of what we do. And each module is linked by clinical case studies. But we don't forget the product either. And I think that's how we have to move. And the other thing perhaps we need to do, which is something else we've done at Nottingham, is start pharmaceutical sciences degrees in our universities as well, for those people who don't want to be a practicing pharmacist but want to specialise in the product. So we've done that as well. Other countries, for example Thailand, which has moved completely to PharmD, has 2 tracks. So for the first 4 years of the 6-year programme, you actually all do the same programme, but then you can specialise in industry or in more clinical, and you can make that decision as a student. But both are qualified as a pharmacist at the end. So there's lots of models to think about. I think I'll finish there because I only have 2 minutes.
So I had two questions. One was on the lab box project. So whoever asked that, I'd ask you to come and see me afterwards because I'm going to address the other one. This was the FIP's role in pharmacy practice. In Kenya, community pharmacy practice run by pharmacists has been on the decline over time. And what role can FIP play in getting pharmacists to community pharmacy? So I want to talk about a couple of things here that FIP is doing. One is there's the largest section in FIP is the community pharmacy section. And they're pretty progressive in their thinking with innovative things that can be done in community pharmacy that's attractive to pharmacists and to the future of community pharmacy. So I would say you should follow the community pharmacy section, and as was already said, you should join FIP and join that community pharmacy section if you're interested. One of the things that I would say is in this question is it's not unique to Kenya. You see this in many areas, and certainly in the US. Community pharmacy has to go through a major transition. It's been the backbone of community pharmacy has been what? Dispensing prescription medicine. In the U.S., it's almost impossible to make a living doing that anymore. A variety of reasons for that. Dispensing is not going to disappear, but I think it's going to disappear from the pharmacist. And as Claire just talked about, technicians, assistants, and so forth. So there's got to be this transition for pharmacists to do other things in community pharmacy. So one of those areas, and I think it's right here on this, on the things you've been talking about today over the last few days, and this is a big push within FIP, is the role of pharmacists in providing primary health care. So it was a big meeting in Astana, Kazakhstan, last October, I think. And the whole thing was the WHO sponsored. The whole thing was on pharmacy and primary health care. And FIP has got a big push now for this. And I think that's someplace that is absolutely essential, and it should be done in the community pharmacy sector. So this is another big area that FIP will be pushing for certain. And all of the innovations that were alluded to a little bit here that are coming our way, and in some cases may exist already. One of those, for example, is pharmacogenomics and pharmacogenetics, and its impact on medication choices, adverse reactions, and so on and so forth. This can be and should be done at the community pharmacy level, and we'll be seeing this happening if, as was already stated by our panelists, if pharmacists can get out of their own way. You've got to be forward-thinking, you have to be progressive, you have to be willing to take the chance and the risk and do it. Get the training you need and do it. And so I think you'll be seeing that coming along. One of the things that happened in the U.S. probably 8-10 years ago is the starting of immunizations in pharmacies. I don't know how many of you do that now, but you know, if I call my primary care physician and ask him about an immunization, you know what his answer is? Go to the pharmacy, because that's where you're going to get them. And so that's where they are now. And that's been a whole new area that has emerged. So those are the things that I would say, and of course there's the advocacy role of getting paid to do all of this kind of work. So advocacy is another very important part of that. So those are the things that I would say are happening within FIP, and if you get engaged with FIP, you'll learn more and more about this stuff. Now, one of the other things I want to talk about very briefly here, because it was mentioned very briefly, but I think it's something that everybody in this room needs to be paying a lot of attention to. Claire mentioned it. It's the impact of technology on healthcare and on pharmacy. It's happening. It's going to happen. It's probably going to happen faster than many of us anticipate. And we need to be knowledgeable about it. We need to bring more technology training into pharmacy curricula and into continuous professional development for practitioners. This is very, very important. And just a shout out for 2020 in Seville, Spain. The theme of the 2020 FIP Congress is the impact of technology on healthcare and pharmacy. And we're busy putting in all of the speakers now. We have sessions already planned. This is going to have a major impact on everybody in this room. And we need to be cognizant of it, and we need to be studying it, we need to be learning it. FIP just started, just announced last month, a new technology forum, so they're going to be focusing on this area as well. So that's the answer I have to that question. Happy to discuss it more if anyone would like to.
Thank you very much. Before I wind down, I would like to introduce the co-moderator, Anilan, my co-moderator. She needs to say hi to the group. She's been working behind the scenes.
Hello, this was a surprise. It's great to be here. I hope you enjoyed the morning session. I do enjoy it and I learned a lot. So thanks to our speakers, wonderful panelists, our moderators, Daniel and Ndinda. I think it was a great session and hope this was beneficial for you. As FIP, we are really proud that we are working in collaboration with our member, KePhSA. So this has been done in collaboration with them, and I think this will continue. I hope to come, we hope to come to your future conferences to so keep this collaboration going. And I hope this was beneficial for you, and hope to have more conversation during the breaks. Thank you very much.
Thank you, Ndinda. Thank you, Vero, panelists, for a good job done, and thank you all for listening. Very many takeaways. We've gone beyond time, but we're making some adjustments to make up for that. We've been challenged, and I think we're up to the challenge, including throwing the box that has been keeping us so constrained in the way we do things in our different levels, right from from the training to our practice. We need to embrace collaboration. We need to support the institutions, ensure that we have needs-based practice-ready training and practitioners. And we really need to align our training and what we do to ensure we achieve and champion quality patient care in PHC, and really to ensure that we achieve our UHC agenda. We've been challenged. We need to keep at it. We need to have a more patient-oriented approach, and patient care is not always at the bedside. We can do it in our community pharmacies, at policy-making level, in the training institutions. As we look at the product, also look at the patient at the end, and we cannot survive without embracing technology, whether it's in e-training, e-learning, CPD, in our practices, and tap into it really to support us to advance our pharmacy practice, pharmaceutical care, and better serve the country and our patients and clients in different places. Thank you very much for your attention. Thank you.